But what I'm going to do this afternoon, obviously, is going to be real session, main sessions that I'm talking about sexually transmissible infections and also sexually transmissible diseases to some extent. As is different between infection and the disease. And then hopefully, if I have time for 50 minutes, as a long time educator, I'm going to talk to medical students about how they should study and prepare themselves to enter into a competitive residency program in the United States. I have been the dean of the medical campus of University of Vermont for some time, and I have been on board of the admission of Yale Medical School for a long time, so I know the challenges of the medical students. Let's focus on sexually transmissible infections. You can look at sex biologically, which is the language of the deep brain system, the limbic system, the driving force to let the species survive. And then also you can look at it as love, but that's very human concept. That's more of the cortical activity of the brain, which is going to modify the biological behavior. But biological behavior is like the feeling of thirst or hunger or being frightened. So these are not in the control of the hormones. They are much stronger biologic desire, particularly because it's the language of the genes to sustain its. And because it's a biologic behavior, many other germs and bugs, they took advantage of this biologic event between humans. And their survival also depends on the chain of sex between the humans. So I need to talk a little about evolutionary adaptation. I told you one time back, we were monkeys and we were on the top of canopies. And obviously, when we were on the top of canopies, mosquitoes start
because they know there is a language, there is communication between microfilaria and the mosquito. Because microfilaria wants to survive. Microfilaria needs to go to the body of the mosquito, and the mosquito needs to carry microfilaria from one human to another human to let the genomic of the microfilaria or the filaria survive. In India, the same group of the worms that release microfilaria during the day. And the mosquitoes, they learn that very quick. And if you go to India, the mosquito are going to bite you during the day, because if they are biting you during the day and you do have filaria, microfilaria are going to be in high concentration during the day. So successful life cycle depends on when the mosquito is going to bite. In Africa, the success of the transfer of the microfilaria is going to happen during the midnight. And then obviously in India is going to be during the day. So if somebody coming from Africa and we believe that person has filaria and we want to make the diagnosis of the filaria, we are going to make blood staining study when we get blood at the middle of the night, because we know the concentration of microfilaria in the blood is the highest. Sexually transmittable germs, they took advantage of the behavior of the sex between the human. They learned that is a very successful pathway, because no one can stop sex. Because if you stop sex, then obviously all of these germs that you are transferred from one human to another human through sexual behavior, you are going to die. Imagine gonorrhea. Imagine herpes simplex. Imagine so many other microorganisms that they are germs of the sexually transmittable diseases. If you stop having sex, we will never have HIV. HIV, now we have 70, 90, probably 80, 90 millions of the people so far have been infected with HIV because of the human has sex. And imagine how many people we are. We are 7, 8 billions of the people. And imagine how many times we have sex. Then you can imagine why this group of the microorganism that I'm going to talk about them today, they have been so successful. There are some definitions that, because most of my audience, they are obviously very young and many of these terminologies is going to be new to them, I'm only just put them on one slide. So urethritis, cervicitis. Cervicitis means the germ is in the endocervix of the woman. Urethritis means the germ is in urethra of man or the woman. Vaginitis, pelvic inflammatory disease, is sexually transmittable disease. If somebody has gonorrhea, gonorrhea may easily ascend through the tubules and get into the peritoneum. Proctitis, if somebody has rectal sex, so obviously then the germ is going to stay in rectum or even ascend to the colon and would give proctitis, proctocolitis. Recently, I had a patient, a young man, a bartender, came with a disease like bloody diarrhea, and everybody was thinking that this is going to be inflammatory bowel disease. Everybody was thinking this is going to be ulcerative colitis. To make the story short, in a matter of fact, it turned to be sexually transmittable disease. That man did have gonorrhea and chlamydia. The other lesson that you need to remember, if somebody has one sexually transmittable disease, you bet that person has the second or maybe a third sexually transmittable disease. I would give you an example. I was in Russia. A girl came from St. Petersburg. She was very young. She was 19 or 20. She was in one of these parties. And then she came down with 5 sexually transmittable diseases. Unfortunately, HIV was one of those five. So HIV is sexually transmittable disease, as you know. Enteritis. So the person may present like inflammatory bowel disease, like Crohn disease, but is not Crohn. It is one of the sexually transmissible germs. Epididymitis in the man, orchitis in man, and genital ulcer disease is completely different category of the sexually transmissible diseases. These are the diseases that would give you ulcer, like chancre, like syphilis, chancroid. These are the ulcers. Herpes simplex, type 1 or type 2 would give you ulcers. I want also to close this slide by letting you know that if anyone has any sexually transmittable disease and that person has HIV, can transfer HIV more successfully. And if someone doesn't have HIV but has sexually transmissible disease, is more susceptible to acquiring HIV. And the reason is very clear because when you have inflammation in the surface of the interaction of HIV with the mucosa, inflammation is going to bring CD4 cells. And the CD4 cells, you know, is the cell, the target cell for the HIV. So then HIV immediately is going to see the CD4, and then immediately is going to jump on the CD4, and the CD4 is going to be infected. This is the reason for some time in Africa, for instance, we were trying to prevent sexually transmissible infections in hope if we are treating sexually transmittable infections, then obviously we are going to prevent or reduce the prevalence and the incidence of the HIV. So sexually transmissible infections, we are potentiating acquiring the HIV or passing the HIV to someone else through the sex. There is also another classification for the sexually transmittable diseases. Bacterial, it could be chancroid, Haemophilus ducreyi, gonorrhea, chlamydia, syphilis. It could be a virus like adenoviruses. Never forget hepatitis A, hepatitis B. These are the sexually transmittable disease as well. Herpes simplex, then warts, papillomavirus, then Kaposi sarcoma, for instance, which is another human herpes viruses. I'm going to talk a little about that. Parasites like lice, like scabies, these are sexually transmittable disease as well. And very recently, in matter of fact, now in the United States, we are dealing with a tinea. Tinea, which is sexually transmittable. The tinea is basically a fungus, a dermatophyte. And now is a form of dermatophyte that we are dealing in the United States, which is sexually transmittable disease. It comes with significant fungal skin infection of the thighs, vulva, scrotum, and genitalia. And obviously, protozoa, you need to think of the trichomonas, and also add to this one amoeba. I know that all of you, whenever you think of amoeba, you will say amoeba histolytica is going to give me diarrhea, give me liver abscess, but it's sexually transmittable parasite as well. So among all of them, I pick up a few. Uh, to be honest, sexually transmittable disease is 4-month course. If somebody wants to know the details of sexually transmittable diseases, obviously you have to go through 4 months, 6 months of very vigorous course in sexually transmittable diseases. So because my audience are very heterogeneous, most of you are students, but I learned that 25, 30 of the nurses and the physicians, they are listening to me remotely. So I'm going to really just try mainly focus on medical students, but here and there, I may do give some practical point to the people who are taking care of the patients with sexually transmittable disease. Neisseria, gonorrhea, cousin of Neisseria meningitidis, your cousin. Whatsoever Neisseria meningitidis can do, Neisseria gonorrhea also can do, including meningitis. Neisseria gonorrhea, you know, that is causing urethritis, cervicitis. I'm going to talk to you later, but may give you pneumonia, may give you tonsillitis, may give you also meningitis. Is Diplococcus, you can see is a diplo, is like beans, two beans coming together, and is gram negative. When I say gram negative, means when you stain, the germ is going to be red. When I say gram positive, means when you stain the germ is blue. So obviously it is red. So this is going to be gram negative, and it is Diplococcus, is biscuit shape, is sticking to each other like two beans. And this is when you do the gram stain, you're going to understand that, in a matter of fact, this is going to be a Neisseria gonorrhea. Culture is easy. We do have some PCR, all of those fancy things, but gram stain probably is going to be the best thing to do. Milk the penis or get very nice sample of the endocervix is a lot of really pus, and then you are going to do a gram stain and you see the diplococci, then you know that you are dealing with Neisseria gonorrhea or meningitis. You know, depends on the context, on the clinical context. And then you can see this all of the pili. These are so essential part of the germ to stick to the endothelium of the urethra, cervix, and the rest. And the major question is going to be when I'm coming and talking about dissemination of the Neisseria meningitidis, you have to know exactly how this bug in endocervix or in urethra is going to detach itself to disseminate. Keyword in gonorrhea, purulent discharge, a lot of pus. This is the endocervix. You would see flow of the pus from the endocervix. Obviously, I told you it can ascend from endocervix to go to the uterus, and then from the tubules may go to the peritoneum, and then from peritoneum, in a matter of fact, even may get to the liver. And the person with gonorrhea may come to you and say, my goodness, I have so much pain in my liver tire. Is in the upper, basically right upper quadrant of the abdomen. And this is all of you know this syndrome, which is Fitz-Hugh-Curtis syndrome. And you can see this is the fibers between glistan capsule, which is around the liver, and this is the liver, and then you would see this is the consequences of the gonococcus. When you have fibrosis, means that the body is recognizing the bug and it's fighting the bug. And look at conjunctivitis. It is purulent, pus drilling down of the eye. I don't know, you have seen newborns with conjunctivitis, because if the mother has gonorrhea in the birth, and then they would see, and the baby eyes is pussy. And then obviously I told you it is very inflammatory. So in the male may cause urethritis with strictures, may give the man prostatitis, otitis, epididymitis. This is all of the local complication of the Neisseria gonorrhea. But what you need to know is pharyngitis. Those who have oral sex, and not necessarily everyone with Neisseria gonorrhea and pharyngitis comes because he or she had oral sex. Some of the people, their finger is contaminated. And then the finger goes to the mouth of the partner. And then the finger, because is carrying Neisseria meningitis or Neisseria gonorrhoeae, you would see the partner is coming down with pharyngitis. Treatment of Neisseria gonorrhoeae, every place is easy except when it is in the throat. The antibiotic that we need to use, the concentration of antibiotic, the dose of the antibiotic is completely different. And we have to keep very close eye. We need to follow up and be certain that the person is free of Neisseria gonorrhea in upper airway. Neisseria gonorrhea, like Neisseria meningitis, would give you bronchopneumonia. These are rare, but definitely happens. Now the question is, we have disseminated form of Neisseria gonorrhoeae. Neisseria gonorrhoeae from the endocervix or from the urethra is going to get into the lymphatic system, get into the circulation, and then is going to disseminate all over the body. How come? If this is a germ, that the body defense against this germ is so much that is producing so much of the pus, how Neisseria meningitis or Neisseria gonorrhoeae is going to disseminate. This serobar of the Neisseria gonorrhoeae are completely different from Neisseria gonorrhoeae that give you plenty of the pus. In a matter of fact, the people who disseminate and they have dissemination form of the Neisseria gonorrhoeae, they're completely asymptomatic. They don't have any urethritis, but you swab the urethra, millions of the Neisseria gonorrhoeae is in the urethra, but you're not inflammatory. You're stay asymptomatic because they don't want you to report to a physician because they want to disseminate. And when they disseminate, they go all over the body. You can see may give you arthritis. This is septic arthritis, elbow, knee, small fingers, but one or two, it is completely different from chikungunya that yesterday I told you is multiple of the joints are inflamed. These are septic arthritis. So if you tap this joint, you can see the germ is living in this joint. And then you would see all of this nodulo-petechial lesion. And if you open one of them and send it for culture, you are going to grow Neisseria gonorrhoeae. So the treatment, obviously, I leave it, you are going to receive all of the slides, and I do not want really to bother you about the treatment A, treatment B. For those of you who are interested, you refer to this deck of slides and see what is the medication of choice. Suffice to say, a year ago, we were using 250 milligram of ceftriaxone and zithromax. Unfortunately, we learned that the germ Neisseria meningitis is learning to become resistant to the azithromycin and also is getting resistant to low dose of ceftriaxone. But now you can see new recommendation is giving only ceftriaxone, but not 250 milligram, but 500 milligram IM, one single injection. Neisseria gonorrhoeae in the United States, like other parts of the world, is becoming one of the superbugs. I'm sure sooner or later, this microorganism is going to be completely resistant to so many of the antibiotics that we have. And this is recommendation regimen of antibiotic for uncomplicated gonococcal infection of pharynx. Then you can see it is different from the other treatment. And now I'm focusing on, by the way, I think really somewhere I did put the gonococcal meningitis and endocarditis. And this is the treatment, just to remind you that gonococcus, when it spreads everywhere into the joint. It can infect the heart, valves, and also it may infect the central nervous system. Now, for vaginitis, I pick up Trichomonas vaginalis, notorious disease, extremely contagious. If the female has it, all of the sexual partner, they do have it. If a man has, all of the sexual partner of that man has this trichomonas. You can see is a parasite, is unicellular parasite, and look at the 4 of the flagella that it has. And look at the amount of the liquidy discharge that it produces, and look at the shape and the color of the endocervix, which looks like a strawberry. So we call it a strawberry cervix. So when you look, you put the speculum and you will see something red with touches of white, like a strawberry. This is going to be Trichomonas vaginalis. And diagnosis is very simple. And just all that you need to do, get a sample, put it on a slide, add 1 drop of normal saline, and then look under the microscope. And then under the microscope, then obviously you would see the parasite. You can see this flagellum, which is very easy. Obviously, when you look under the microscope, you see they are moving because they are moving unicellular parasites. And a treatment is easy, is metronidazole. But the question is basically you need also to track all of the sexual partners and give them treatment. Otherwise, the woman or the man is going to come down again with Trichomonas vaginalis. And the second is the bacterial vaginosis. And the bacterial vaginosis obviously is not vaginitis, so it's not inflammatory, because whenever you have appendicitis, means inflammation of appendix. Hepatitis means inflammation of the liver. Vaginitis means inflammation of vagina. But when you say vaginosis, means the vagina is ill, but is not inflamed. And we don't know exactly what's going on, to be honest. Is it a sexually transmittable disease? We don't know. But we know that the microorganism of vagina, the normal flora of vagina, they are completely different. Normal flora of vagina is lactobacillus that is producing lactic acid. So the pH of the vagina is low because of the lactic acid production of lactobacillus. And that low pH would not let any other germ to find a foodstuff in a vagina. But here you would see different microorganisms, Gardnerella or Mobiloncus species. These are not normal flora of the vagina. These are absolutely abnormal. So what is happening in vaginosis is disturbance in ecosystem of the vagina. Vagina has different pH now, pH is not very low, and then would let other microorganisms to come, and then you have multiple microorganisms growing in vagina, and then it's causing a lot of really symptoms in the woman. And to make the diagnosis is very simple. The discharge is thin, is gray. Vaginal pH is more than 4.5. And then you do VIF test. And what is VIF test? You add 1 drop of 10% of the KOH, potassium hydroxide, and then the amine is going to release and is fishy smell. Amine, because all of the fish, if you leave it for some time, the smell of the fish is from the amine production. So, and then you have clue cells. And what is clue cells is very simple. You get, again, a sample of this discharge, you put it on a slide, add 1 drop of the normal saline, and then you will see these epithelial cells, and then covered by microorganisms. This what we call it clue cells. So clue cells is epithelial cells of vagina, and then covered by thousands of microorganisms. And this is something that comes to the test very often. What are the 4 features of the bacterial vaginosis? All the time you need to remember that the pH is more than 4.5, positive WIF, and then clue cells, and the discharge is thin and gray. And the treatment is very easy. And this is a slide for those of you interested to know exactly how we need to treat. But unfortunately, it comes back again and again and again. And you treat because when the microorganisms, they come and find a new territory, the germs are so territorial. They do not let you to throw them away. For instance, because this is a very important concept, you can map my tongue based on the germs in each part of my tongue. And they have their own country. Like this is United States, this is Canada, this is Caribbean islands. Each of that piece, a small area of my tongue, has been claimed by very specific microorganism. Now, if you have intruder and if they come and they conquer that land in your body, it is hardly to be expelled. And vulvovaginal candidiasis, unfortunately, is very common. It is not only sexually transmittable disease, but you know that if you put somebody on very high dose of antibiotic, and the patient is going to come down with candidiasis of the mouth and vagina. If you put somebody on doxycycline, for instance, many of our students, they go to Africa for clinical rotation, and we give them doxycycline for malaria, for prophylaxis against malaria, and they come down with candidiasis of the vagina very badly. And also, the people who have basically chemotherapy, they may come down with candidiasis of the vagina, but unfortunately is very bothersome, is itchy, and but the discharge is curdy, is like milk, and treatment is easy, is not hard. Now I'm going to talk about genital ulcer disease. So I talk about gonorrhea as prototype of urethritis, cervicitis, endocervicitis. I talk about 2 topics about, or 3 topics about vaginal infection. Trichomonas, and then I did talk about non-specific vaginosis, and I talk about vulvovaginal candidiasis. Now, talking about genital ulcers. And here I'm going to talk about herpes viruses. But never forget, when we are talking about genital ulcer disease, syphilis is genital ulcer disease, chancroid is genital ulcer disease. But I'm not going to touch any of those. I'm going to only pick up one of the major ones, which is herpes simplex. In United States, syphilis is shooting up. Amazing. Particularly among men who have sex with men, the syphilis now is a major problem. Herpes viruses, they came to a stage. On the other hand, when you get herpes virus, you are going to carry that virus to your grave. You are going to be with you. There is no way that you can get rid of the herpes viruses. unfortunately. Amazingly, the body puts a lot of energy to control herpes viruses when they are in your body. I would give you the names of the herpes viruses. You can see herpes simplex virus type 1, type 2, varicella zoster virus is herpes virus, chickenpox, and also shingle is the same category of the viruses. CMV, and that those of you who are pediatrician, you are familiar with the pregnancy, the consequences of pregnancy, and basically CMV on the pregnant woman, and also on the newborn. Epstein-Barr virus, which is infectious mono hissing disease, is one of the herpes viruses. Human herpes virus 6, human herpes virus 7, and human herpes virus 8, which is Kaposi sarcoma virus. And Kaposi sarcoma virus obviously is a human herpes virus. All of these viruses, when they come to your body, they are going to stay in your body. They have a hiding place, and they are going to stay forever. I learned very recently that 25% of our defense goes toward controlling CMV. Imagine 25% of your immunity, the soldiers, all of them, they are targeting CMV not to eradicate CMV, just to control CMV. And the CMV is a major virus in transplant population. As you know, bone marrow transplant population, the lung transplant, kidney transplant. All the time you are going to learn about the CMV and how you can control CMV when particularly the patient is immunodeficient. HIV, when the CD4 cell gets to 100 or 50, you have the CMV retinitis that makes the man or the woman blind. It gives you GI bleeding because of the big ulcers, for instance, give you meningoencephalitis. So this is the virus that comes, unfortunately, is going to stay with you for the rest of the body. And this is herpes simplex, just to see this is a big virus, is a DNA virus. So yesterday and the day before, when I was talking about arthroviruses, alpha viruses, they were RNA viruses, but this is the DNA viruses. Are the DNA more successful? But you need to remember the DNA of the virus is humanoid because we are DNA creatures. And that's the reason that HIV, which is RNA virus, is successful because it's retrovirus. What I mean by retrovirus is RNA virus, but gets to the cell, it becomes DNA virus, and then goes to the nucleus, and then becomes a part of the nucleus of the human. I'm just showing you the cartoon of herpes simplex virus 1 is complex, and then you need to know when the virus comes, assume comes to the skin, is going to ascend the dendritic or the dendrites or the schwanns, and then they get into the neurons. This is one of the neurons in one of the ganglion of the spinal cord or in the base of the brain, and it's going to become a part of the nucleus, and then it's going to be dormant, and then suddenly, God knows when and why, it's going to activate itself. Now it's going to come out of the nucleus and it's going to descend, and then suddenly you are going to have blisters on the corner of your lip, for instance. And the most common cause of genital ulcer disease worldwide is HSV2, but now United States, HSV1 is taking over the HSV2. HSV1, obviously the child, when he's born, when the mother is kissing the child because the mother has has the herpes, and the herpes virus constantly or intermittently is going to be secreted in the upper airway. So saliva is infected with the virus and it's going to go to the mouth of the baby, and the baby is coming with the first attack of the herpes simplex. So initial infection is horrible, is more severe, and then you can see the initial infection, and HSV1 and HSV2 is almost the same. Look at the vulva. It is so ulcerative. It is very inflammatory, but this is the first attack. So now what would happen to the virus? This virus now is going to ascend and go and hides in one of the basically uh, nodes in some part of the central nervous system or the spinal cord or brain. Is going to be dormant, is going to be a part of the nucleus. And then from now on, um, this person is going to be contagious. Maybe every day is going to shed the virus 3 times, maybe sometime for 2 months. This gentleman or this woman is not going to shed the virus, but then suddenly again is going to come, and the man or the woman who has been infected with one attack of HSV 1 or 2 in genital area has potential to spread the virus for the rest of his or her life. The recurrence sometimes is nothing. I have seen girls, for instance, they come to my office and they will say, listen, I have some dysuria. I have literally burning when I pee. When I investigate, I would say that in a matter of fact, this girl is shedding the virus, is relapsing the herpes simplex. And sometimes it's going to be blisters, it's going to be very painful, but usually the relapses are much milder than the first attack. The point that, or the key point that you need to remember, if the patient is asymptomatic, it doesn't mean that that person is not shedding the virus. It may not shed the virus, but the chance that this person is going to shed the virus sometimes is substantial. We did very good study in the United States, and they looked into a group of the men and the women who had herpes simplex, vaginalis, or urethritis. And then we followed them for years, and we checked with the PCR, the vaginal discharge or urethral discharge. Even in 24 hours, there were times that the person had no virus, but then there were times that the patient did have the virus. So the virus is intermittent. It could be hourly intermittent. It could be weekly intermittent. It could be every 6 months intermittent. But the virus is going to be present in vaginal secretion and urethral secretion and semen. And asymptomatic reactivation in a matter of fact is driving force behind the epidemic of the HSV in the entire world. The shedding particularly is highest in the first 3 months after reactivation or acquiring the first attack of the herpes simplex. And there are multiple tests that bother you, how you need really to make the diagnosis of herpes simplex in this part of the world. I think is going to be clinically. It is painful, it is ulcerative, there are multiple lesions, there are blisters, but now the one that we use very often is NAT, or nucleic acid amplification test, and we have the NAT for almost all of the sexually transmittable diseases. So if a woman and man come with sexually transmittable disease, we get basically a sample, and we send for 10, 11 types of the bugs and the germ that produce the sexually transmittable disease. What about serological tests? And this is good to know that serological tests are meaningless. They are good only for surveillance and to know how many percent of your population you are infected with the virus. but they are not going to tell you if that person at that point of time is shedding the virus or is not shedding the virus. So if I do, for instance, randomly a sample of your blood and send it for the glycoprotein antibodies of the herpes simplex 1 and herpes simplex 2, 100% of you are going to have antibody against herpes simplex 1 because you got it from your mother or your father birth. And then probably 60% of you are going to have HSV2, which was sexually transmittable and came to your body later on. The people who have sexually transmittable disease by HSV1, when they come down with HSV2, the disease is mild. On the other hand, HSV1 to some extent is going to protect the severity of the HSV2. Treatment now, it is very easy. We have so many different type of the medication, acyclovir, valcyclovir, famciclovir, and in a matter of fact now in the United States, we are using valcyclovir and famciclovir, and sometimes even one dose is enough. So we went from 10 days treatment to 7 days treatment, then to 3 days of the treatment, and now with very absorbable acyclovir formulas, all of them, they are family of acyclovir. But acyclovir GI absorption is not very good. But if you go to famciclovir, which is prodrug for acyclovir, the absorption is perfect, and one dose would be enough, for instance, to treat herpes simplex. But what about somebody would come to you and would say, listen, put me on suppressive therapy. Just give me this medication and I would take it every single day. Does that treatment is going to reduce the number of the virus that I shed in 24 hours? The answer is yes, but it's not going to 100% reduce it. It's going to reduce it substantially, but still taking acyclovir on daily basis, you're going to have certain amount of the virus at certain time in the urogenital secretions. Okay, so I think really I went through this one. The only thing is pregnant woman, you know, is a nightmare if you are dealing with a pregnant woman that has active ulceration in the birth canal. Because if the virus from birth canal gets to the newborn, you have disseminated herpes simplex in the newborn, encephalitis, hepatitis, you mentioned, is a disaster really in the newborn. And for ulcer disease, I pick up granuloma inguinale very intentionally because we don't see it in United States, but it is in Caribbean islands. The germ is Klebsiella, and one of the species of Klebsiella is Klebsiella granulomatis, and is gram-negative rod, encapsulated, and all the time is a big ulcer, bleedy ulcer, ugly ulcer. And when you take a sample and you look under the microscope after staining, you have to look for Donovan bodies. And this, as you can see, this is the mononuclear cell, monocytes, and then inside you will see Klebsiella. So myriads of the Klebsiella engulfed in this mononuclear cell. So this is the way that you are going to make the diagnosis. But here you can see limited geographically, tropical, including India, and also in Australia, in New Guinea, and in Caribbean islands. There have been reports of this genital ulcer disease. And this is basically the lesion, and I have seen a few of them in South Africa and even in Congo. And you would see it is really deep, ulcerative, and sometimes would give you masses in inguinal area and is ugly looking really lesion. Now coming to human papilloma virus, and you know the papilloma viruses. And you know the papilloma viruses, these are the DNA genome, and papilloma viruses would give you warts, but that's benign. But unfortunately, papilloma viruses would give you endocervical cancer, and many of the youths is going to pick it up. And then by the age of 35, 40, some of them, they have endocervical cancer, even metastasize distantly, and high mortality, painful death in many of the women all over the world. But as you know, we do have a very good vaccine. This is the anogenital warts. Sometimes, particularly in patients with AIDS, these warts is growing like a big mass of the mushroom, very, very malodorous. In Botswana, I was in sexually transmittable uh, disease center, and I could easily say who has the warts. That person who comes with very bad odor, I knew that I'm dealing with advanced warts in somebody who has the HIV, unfortunately. And then you will see condylomata aquinata at the mass, as you can see, but sometimes there are only few on the dorsum of the hand. Sometimes it's going to be on the upper airway, and endocervical cancer in the woman, but also the upper airway cancer in men, which is squamous cell carcinoma of the upper airway, is the consequences of the papilloma virus. It's oncogenic virus. It's like hepatitis B. It's oncogenic virus, can cause cancer. Obviously, we have very highly effective vaccine. I'm not going to go through basically the schedule of the vaccine, but hopefully all of you have received the vaccine when you were a child or when you were 13 or 14. And then never forget other sexually transmittable viruses, hepatitis A, hepatitis B, hepatitis A, particularly in those who have men who have sex with men. Hepatitis A obviously is going to be in GI system. So if the finger is becoming contaminated, then goes to the mouth of your partner, then obviously hepatitis A is going to be transmitted. Enteric pathogen, Campylobacter, Entamoeba histolytica, Giardia lamblia, Salmonella, and Shigella. All of them, they can be sexually transmittable, particularly who have rectal sex practice. And this is Entamoeba histolytica in a gay man, in a man who has the sex with man. So obviously the partner had Entamoeba histolytica in the GI system, and insertive sex transferred the Entamoeba histolytica to the penis of this man, and then to the, you would see for the person, the woman, and also the rectum of the man, you would see mass ulceration. Entamoeba histolytica means what? Means if you put entamoeba on your tissue, is going to dissolve tissue. Histolytica means dissolving the tissue. And then pox viruses. We have two different pox viruses that are sexually transmittable. Molluscum contagiosum. Some of you, when you were a child, probably you had a few of them on the dorsum of your hand. That's common and it goes away gradually. Is a pox virus, very complex virus, very big virus. Is like a bullet, and this is the molluscum contagiosum. The lesion is umbilicated. You know, at the center, you can see umbilication. You see like a crater of the volcano. Is a pit at the center of the lesion. This is classic lesion of the molluscum contagiosum. And HIV, it grows particularly around the eyes and is one of the AIDS defining illnesses. You may have molluscum contagiosum as a child on the dorsum of your hand or the dorsum of your foot. But if you see anyone with molluscum contagiosum around the eye, that is AIDS. By definition, that is AIDS, and no other disease would give you or reactivation of the molluscum contagiosum around the eye. What is the treatment of the molluscum contagiosum in AIDS? Is a treatment of AIDS. Put the patient on antiretroviral medication in less than 3, 4, 5 months. All of these lesions are going to go away. I did have a patient in Uganda that was a child, I think about 7 or 8 year old, had the even worse than this child. And then the teacher was popping each lesion between the fingers. Every single day, the child would go to the nurse and somebody would pop up this lesion. That was the remedy available to that community in early 2000. And this is the vulva and the thighs, and then this emulsion contagiosum of the penis. And now coming to the monkeypox, because it's a news all the time. Obviously, I do not have time to explore and explicitly, basically talk about the monkeypox, but is misnomer. Is not the pox of the monkeys. Monkeys is like human, is incidental host. The first time that we described this virus were in monkeys in Europe. That they were obviously the monkeys they they came from. They brought them from Africa, but it was described in monkeys. But in a matter of fact, if you look at the life cycle, you will see mainly the small rodents. They carry this virus, which is a pox virus. Squirrels, you would see. Uh, Harari's dog in United States, there was outbreak among them almost 10 years ago. And then obviously it can give it to human or it can give it to the monkey. Looks like a smallpox, unfortunately. Right now, there is new epidemic in Congo. Probably you're following that. A new strain of the 2A of the monkeypox virus in Congo. Previously, we had many cases of the type 1 among men who had sex with men, and they went for a festival in Spain, and then from Spain, they brought the virus all over the world, including in United States, in Canada, and other parts. This is the monkeypox, a very bad disease, and these are the evolution of the pustule. Looks like a smallpox. You would see is very bad. Mortality could be as high as 10%, and particularly if somebody has HIV, look at the shape of the nose of this person with HIV and monkeypox. Vaginitis has been reported recently. It was sexually transmittable disease. Never was sexually transmittable disease, but now it is sexually transmittable disease and needs contact, really intimacy. And if somebody has the lesion, then during intimacy, the virus can easily get. And we had the lesion in genitalia, in the rectum. Proctitis was reported, vaginitis was reported with this new epidemic of the monkeypox in United States and in Europe. Few of my final slides, lice, scabies, please never forget that. I had a college student recently came to me and he was suffering from itch around the neck and itch around genitalia. And to make the story short, it was lice. And this is a female crab louse. And then you can see the lice in pubic area, and treatment is easy. There are so many shampoos or malathion or ivermectin already you can use, but very common, obviously, as a non-sexually transmittable disease is very common among the children in a school. And then scabies mite is sexually transmittable disease as well. All of you remember that it goes between the fingers first, under the breast. And this is the disease that give very bad itch. And person comes with the worst itch ever, scratching the body from head to the toe all the time. And don't think that person has more than 7 or 8 scabies in the body. maybe one or two between the fingers, a couple of them under the breast or maybe axilla, but the rest is hypersensitivity of the body to the excreta of this mite. And the ink test, you remember what is the ink test? What you do, you put only one drop of the ink between the finger, and this is the tunnel. This is the tunnel, and here probably is the mite. And then when you put the ink is going to go subcutaneously, is going to show you the canal. And then you take a pin, and then you go to the head and just pin the mite out. That's very easy to make the diagnosis of the scabies. And this is a scabies of the genitalia and another scabies of genitalia, and then sometimes cause eczema-like hand condition. Particularly, you need to remember the Norwegian scabies, and this is in immunocompromised host. People who are on hemodialysis, the people who have diabetes mellitus, or they have very far advanced kidney disease, they come with Norwegian scabies. Obviously, people with AIDS, they come with Norwegian scabies, and each piece of this tissue here is loaded with this mite, very contagious. I remember one time we had a patient with far advanced kidney disease, went into the ICU, and he was itching all over the body, but we didn't notice it from renal failure because, uremia is one of the causes of itch. And many of us, we didn't use gloves or protection. I think 11 of us in that unit came down with scabies. But the treatment is going to be very easy, is permethrin cream 5% or ivermectin oral tablets is going to be the medication of choice. Okay, it's 4:11. Unfortunately, we start 9 minutes late, so I'm only 2 minutes over time. So I stop here, and if you have any question, I would be delighted to answer. But as I said again, this is only uh, you know, uh, the tip of the iceberg. I just wants to open a new window to your life and your medical school content of the curriculum, just to see. I know that you are very focused on what would take you through the USMLE 1 and USMLE 2, but I thought really it's better to know a little about sexually transmittable diseases. Do you know to what age is at highest risk for sexually transmittable disease? 15 to 22. So this is the highest risk group basically for sexually transmittable diseases. Okay, there was a question. Fantastic question. So is why we do have this Klebsiella in this part of the world, but not in western part of the world. But there is something to do with the climate. The bug is easy to be grown. Klebsiellas, as you know, they are common microflora of the hospitals, but not this one. Klebsiella pneumoniae, for instance, oxytoca. Those Klebsiellas, they are common cause of the kidney infection, pneumonia, soft tissue infection. But this is very unique to certain part of the world. But imagine also it is in Australia. I don't know, but I bet there would be some literature and that you can dig into it and educate yourself and send me an email and educate me too. Thank you very much. Yes, about monkeypox. Okay, so Monkeypox obviously originally was described in Congo and is among kids. And we believe because the kids they are in environment playing, and because the rodents they are carrier of the monkeypox, they probably contaminate the environment, and the kids because he's constantly in touch with the soil playing. So that's the major reason that the virus is going to get to the kids. Is not sexually transmittable disease in Congo. It became sexually transmittable disease very recently when there was a festival for the gay people in Spain, and also I think really in Paris. That festival attracts substantial number of the gays, and some of them were coming from Congo or other places. They did have the monkeypox, and then during the sex intimacy, you know, uh, the friction between the skin, for instance, spread the virus from one to the other. That was the only way that it became sexually transmittable. Even, you know, even if you, for instance, some of them they use condom, but still they acquired it because not necessarily the virus was in genitalia. Some of them they had a couple of really pustules in other parts of the body. So, and the condom, for instance, can prevent certain number of the sexually transmittable diseases, but not all of them, as you know. Papilloma virus, for instance, is notorious. Papilloma virus, for instance, warts, uh, is not going to be prevented by the condom because sometimes the skin of the thighs is shedding the virus or contaminated by the virus. And monkeypox is the same. You cannot really prevent it by using the condom. You have to be extremely. We do have medication though. We have vaccine for that. We didn't have really time to go over the vaccination for the monkeypox. The vaccination of the monkeypox is the smallpox vaccination. A smallpox vaccination, which is very effective for a smallpox because we control the smallpox, also is very effective for the monkeypox. Why we did have this new outbreak of the monkeypox in Africa? Because we stopped giving a smallpox vaccination. Previously, when we were inoculated the people for a smallpox, that would give cross immunity against the monkeypox. But we stopped doing that because there is no new smallpox anywhere on the world. There is no reason for giving the people a smallpox vaccine. That is one of the major reasons for the new outbreak. Those kids, these are recent photos from the new kids in Congo. These new kids, unfortunately, they have not been vaccinated against smallpox. Yes. Very good question. So the question is basically, how come the body spends 25% of its energy to confine this virus? CMV is immunomodule virus. It's not only cytolytic virus, it is also immunomodulating virus. It's going to play with your immunity constantly. And the body tricks body, and the body needs really to come to a new way or new line of the soldiers for this newly transformed virus. This virus constantly transforming itself to hide itself from the body, to stay in the body till the end. Make the person a little immunodeficient, then the virus is going to pop up. For instance, put somebody on corticosteroid, the patient may come down with reactivation of the CMV. Somebody with renal transplant, you are putting the patient on immunosuppressive medication for prevention of the solid organ rejection, basically. the person is going to come down with the CMV. CMV pneumonitis is notorious in bone marrow transplants. CMV meningoencephalitis, retinitis, esophagitis, colitis is notorious in AIDS population. So it's immunomodulatory, plays with the immunity of the body, and the body constantly needs really to train the new soldiers for that. 25%, it is unbelievable. There are books written about the immunity of the CMV in the body. And we, as we were speaking, in a matter of fact, in 2000, in 1985, I was in the lab studying to make a vaccine for the CMV. My boss was very successful to get close to the vaccine, but as we are speaking, still we do not have a successful vaccine for the CMV because of the tricks. This is the story with HIV, the same thing. The HIV also constantly is changing the shape and the body, paralyzing the body and paralyzing the scientific community to come to a very good vaccine for HIV. Okay, so thank you very, very much. This is the end of the sessions. I'm sorry, I knew that your majority of you obviously are medical students. Yes, we can talk for the 15 minutes. Yes, okay. And so, yes, disaster. Yes, for the uh, has been the challenge for making any vaccine for the herpes has been amazingly a challenge. But assume we have the vaccine. Who should receive the vaccine? Because the mother gives it to the baby. That's the first step. If you're talking about HSV2, basically, not HSV1, because HSV1 comes to our body on day one of the life, you know, and for HSV2 is a challenge. The antibodies, already, as I said again, somebody may get the HSV1 or HSV2, and then is going to come down with another HSV. So body doesn't make much of the sustainable immunity against these viruses. These viruses constantly are shedding. So they are invading my body, and I do have immunity against them because I suppress them. But then for 2 months, and then after 2 months, again, I shed the virus. So this means even natural acquisition of this group of the viruses is not going to give you immunity. One of my mentors taught me many years back, said, if natural disease is not going to give you immunity, good luck if you want to make a vaccine to do the job. Because when, for instance, imagine right now for COVID, SARS, obviously the people come down with COVID-19 often, but still they may come down with the second attack, they may come with third attack, they may come with the fourth attack. That's the reason the vaccine also has been very challenging. The vaccine in COVID is helping me only for 4 months. Recommendation now from the CDC for the people who are 65 or more is biannual vaccination against COVID-19. So sometimes they trick us. Okay, we have to make it very specific to any of these pathogens. But for SARS, so we know 50% of the people are asymptomatic. But for herpes, in women particularly, majority of them, they are asymptomatic, the females. And amazingly, transmissibility of the virus also is more from woman to the man than the man to the woman. So there are some biological differences also in all of these pathogens. But this doesn't mean that the men would not be asymptomatic also. Okay, so I want a little talk, maybe for 10 minutes, tell you my experience with medical students and who were successful and who struggled. And this is based on the fact that I was the dean of the medical school for the University of Vermont at clinical campus in Connecticut. And I was sitting in the board of the admission of the medical students of many universities. And I have been through AAMC site visits more than 3 times in my life. And I have 4 children, 3 of them, they are physicians. So 3 out of 4. You have to give me credit. Because I love medicine. I think everyone who is a smart needs to be a doctor. And all of you are smart and you will be very good doctors. And as I said, don't come to medicine because it would give you a bigger house or a better life. Find joy in what you do as a physician. Being a doctor is very challenging because it's a mix of all of the challenges. It's not only the medical part of the medicine, which is attractive. I can talk about viruses forever. I can talk about the hematological, hematology, or endocrinology. All of those fields are so beautiful. You would never, ever, it doesn't matter, even you are genius, this field would never be boring for you. That's the content. That's the science, the basic science, the clinical science. Social part is a challenge. You're in emergency department dealing with a pregnant woman that has no insurance and is coming from the southern part of the suburb. How you want to deal with that person? Budget-wise, administrative-wise, so ethical-wise. So is the, I would say, optimal field for somebody who wants to be totally consumed and engaged. And I'm sure all of you are smart because you have been through multiple process to get to this seat. It has not been easy. You sweat on that, your father, your mother, your kid, everyone has been with you, you know, and when you got the admission, I'm sure that so many of the people around you, they cheer up and they enjoyed your success. And I know that living in an island is not easy. It's a small island, you're away from your family, but you need to remember this is 2 years and you have a dream to get to. Some of the writers, they wrote their best books in prison. Dostoevsky, a Russian amazing writer, wrote Underground Notes, which is one of the best psychological books when he was in exile, and wrote it between the Bible because nobody gave him a piece of the paper. So he wrote the novel between the lines in a Bible. You have a dream that you need to reach. First, be regimental, be scientifically regimental. I mean by scientifically regimental, You need to know from 8 o'clock or 7 o'clock in the morning what you will be doing every single day till 8 or 10 o'clock at night. You can't make your day when you're getting up in the early morning. No, you have to have a plan. You need entertainment. Obviously, you need entertainment, but it should be a schedule. Not when somebody sends you email or a message that let's go for Z or Y. I say, here I am, I'm ready. No, you are not ready. If this is movie time, is movie time. Is Saturday or Sunday or sometimes is in your schedule is movie time. You have to be scientifically regimental and be harsh on yourself. You punish yourself. If you are deviating from scientific regimen, you have to punish yourself. You say, listen, I did something wrong. Yesterday, 2 hours, I supposed to do something. I didn't. I was tired. I was sleeping. Now I'm going to add to my schedule 2 hour more. And then start really read and systematic reading. I know that you're going to prioritize things, focusing on right now is block of cardiology probably. Next week my son is going to be here. I'm sure that is going to be cardiology. You're going to focus on cardiology. That's wonderful. Have notes and then review your notes, but don't confine yourself to the notes and to the class. You have to have a textbook and you have to study every single thing in deep. I know it is going to be too much, but pick up one topic that is close to your heart. Learn that one deep, 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 deep. Then you can use your brain is going to get used to be very deep when it comes to another subject. Train yourself to be methodological in studying by picking up one field. Imagine, for instance, bone marrow or lung or heart, something, but learn it deep, deep, deep. If you want to be very great in cardiology, just learn everything possible about cardiology. When it is this rhythm and this is abnormal, why? The way the question that you asked me, why Klebsiella is not a common disease in United States? Answer it. When the question comes, don't pass out of that question easy. Write a couple of questions a day. I say when I get in home, I'm going to deeply look into these questions. Deep. And nothing more beautiful than details. When you know the details, you will be successful. USMLE 1 is the key. Pass it. Don't fail USMLE 1. Don't fail it. Do your best and pass it. It's pass and fail. So it's good and bad. It's good because nobody knows your score. So when you're applying to a residency program, I was the director of residency program at Yale for almost 20 years. But I did have the score of the USMLE 1 in front of my eyes. But right now, I don't. So then what I need to do, how I should differentiate between two students that both of them, they passed USMLE 1 and they have similar scores on USMLE 2. Assume 250, something of that score, that's right, is research. What makes two students separate and push that student up is the student who has done research. So find a topic, find a topic yourself. Because I have seen a student doing research, they come to me and they are number 10 on the paper. I say, okay, what was your function? She would say, listen, the principal investigator gave me some chores and I went to the library and I, you know, contribute in some way. That's not good research. Idea needs to come from you. You have to come to a research project, find a mentor, find collaborator, and start working together on that research project. It is not hard. It is easy, but it has to be a part of your work, research. Then coming to USMLE 2, then obviously the more the score, the higher score is better. But if you are American, graduate from medical school, I think really any grade is going to be good. Because I don't know why you are not putting everybody in a same box and say, I'm going to pick up the best. That is not going to happen. They are going to have two bags of the students who are graduate from the inland, and then the bag of the students who are coming from outside. And from outside, there are two groups coming from this type of medical schools, Ross, St. George's, AUC, and American Canadian Medical School or School of Medicine. And the second is going to be the people who are being graduating from other parts of the world, from England, from Italy, from Iran, from Iraq, from Russia, for instance. You are priority. So the priority number one is going to be inland graduates. Priority number two is going to be you people because you have paid taxes. So we know as the director of residency program that your parents, they have paid tax. They are Americans, and you people, you are getting loans and you have to pay your loan and all of those obligations, obviously you are going to be priority. No question on that. And this school is new, obviously, but what makes this school sort of unique is the fact that the Canadian Royal College of the Physicians and Surgeons is raising hand and will say, listen, I'm supporting this. I'm accredited this school. There is no other school offshore with that credibility. But the name needs to get out. Right now, I have many friends in Canada. Recently, I talked to one of them and I said, I'm heading to Dominica, and they knew very well, to my surprise, completely well about the American Canadian School of Medicine. So it is very well known in Canada. Then you need clerkship. I know there is a time, there is a deadline that you need to submit application. They need to find basically a place for you for your clinical work. When you get your clerkship, try to identify 2 or 3 people that they know you well and you know them well, work with them very closely because they need to write you a letter of recommendation. But this is something beyond the letter of recommendation. When you go to a place and you find that place good for you, if you make very good impact on the people in that institution, you bet you are going to be matched for that institution much more than being matched for another institution. Because if assume you have been assigned to my team, and then at the end, I'm very much impressed by you, then I would go to director of residency program. I would say, I want this young woman as my intern. That pushes your application immediately up on match. You have very good chance, but to make it happen, you need to start from right now Don't study superficially. Memorization all the time is good when they come to the exam, but before you get to that place, you need to understand the concepts very, very well. I didn't start memorizing some of the flashcards. I know that all of you are dependent on that. All of those things good, but deep reading is unavoidable if you want to be very successful in medical school. And good luck. Okay. Any question? Okay. Thank you very much. Thank you.